Now, ma'am. Hello, doctors. I am Dr. Senthilkumar. I am a consultant neurosurgeon in Hannah Joseph Hospital, Madurai. I am going to lead a neurosurgery for Assure team. So, already one topic was over regarding a head injury, which was taken by Dr. Rahul. So now we move on to ventricular anatomy, CSF, and hydrocephalus. We will schedule it in a way that you can easily approach neurosurgery and you can understand the concepts. So with that introduction, we will start our class. There are four ventricles in the brain. There is two lateral ventricle, one third ventricle, and one fourth ventricle. The lateral ventricle communicate to the third ventricle through foramen of Monroe, and third ventricle communicates to fourth ventricle through cerebral aqueduct, and fourth ventricle will communicate with the subarachnoid space through foramen of Lashka, which was located on the lateral side, and foramen of Magenti, which was located on the center. And also it communicates to the central canal of spinal cord through the central canal, which is located below the obex. So lateral ventricle was further divided into anterior horn, posterior horn, temporal horn, and the central part was the body. These three horns will meet together in a place called atrium. So these are the parts of the lateral ventricle. Anterior horn was also called as frontal horn. Posterior horn is also called as occipital horn, and inferior horn is also called as temporal horn. This is the picture which shows the parts of the lateral ventricle and the lateral ventricle, how it communicates with the third and fourth ventricle. With that introduction, we'll move on. So we'll say the MCQ straight away. We will structure this class in a way that how neurosurgery was asked in AIIMS and other reputed institutions, and past NEET super specialty based questions. With that, we will structure this topic. Not only this topic, we will approach all those topics through MCQ based questions only. In that, we will elaborately explain each and every important tricks, why they ask these questions, and how to approach this question. The first question is structures related to body of lateral ventricles except caudate nucleus, hippocampus, stria terminalis, corpus callosum. Unless you know the anatomy of the lateral ventricle, you cannot answer this question. So we will see the lateral ventricle anatomy. So this is the lateral ventricle boundaries based on the four cut sections: anterior horn, temporal horn, posterior horn, and atrium. We'll see one by one. First, we'll see the frontal, that is anterior horn. This is a cut section of the anterior horn. It's a coronal cut section, and it clearly depicts the boundary. This anterior horn is this. The cavity of anterior horn is showed as a violet purple shadow. This picture was taken from interpiercing neuroanatomy. Medially located is a septum pellucidum, and below that there is a rostrum of corpus callosum. Structure which medially located to the anterior horn of lateral ventricles are two. One is septum pellucidum and another is a rostrum of corpus callosum. And laterally is located by caudate nucleus. This caudate nucleus will run all along the lateral ventricle, but in a different way it is related to the lateral ventricle. Superiorly, corpus callosum forms the boundary. So these are the three boundaries which form the anterior, which was located in the anterior horn of lateral ventricle. And the body of lateral ventricle, the structures laterally located are caudate nucleus, stria terminalis, thalamostriate vein. This is a frequently asked question is, usually they will ask stria terminalis and thalamostriate vein, where it is located, whether it is located laterally or inferiorly or medially or superiorly. So this thalamostriate vein and stria terminalis and caudate nucleus all will run together. So this is a simple clue. Caudate nucleus, stria terminalis and thalamostriate vein all always run together, and these two structures always located between caudate and thalamus. So the body of lateral ventricle is inferiorly located by thalamus and medially by septum pellucidum and body of fornix and superiorly by corpus callosum. So if you memorize these two pictures or the total four pictures, you can crack this MCQ. It's one of the frequently asked questions, the boundaries of the ventricles. So with this, we can solve this MCQ. The structures related to the body of lateral ventricles are except caudate nucleus, hippocampus, striatum terminalis, corpus callosum. The answer is hippocampus. You see these pictures, the body of lateral ventricle is related to caudate nucleus, that is A, striatum terminalis, which is located below the caudate nucleus, C, corpus callosum, which is located above. But they had written hippocampus, which is not related to the body of lateral ventricle. It is actually related to the temporal horn of lateral ventricle. So if you know this picture only, you can answer this question. It was asked in AIIMS. This question was asked some 2 years before in AIIMS. Then we will move on to occipital horn of lateral ventricle. Occipital horn of lateral ventricle, laterally tapetum and optic radiation will come. This is another frequently asked questions. Optic radiations are located on which side of the occipital horn? It's a medial side or a lateral side? The answer is lateral side. And medial side, fibers of forceps major goes. So they usually jump. Usually the twist they will keep is a forceps minor fibers. They will ask in an MCQ, they will ask a forceps minor. So we have to be very careful. It is a forceps major, not forceps minor. And also the calcarine sulcus will form a dip. There are two dips, two indentations in the occipital horn. One is formed by forceps major and another is formed by calcarine sulcus. That dip is called calcarine alvis. You can see in that picture. And lastly, temporal horn. The temporal horn of lateral ventricles, the structures medially located to it are stria terminalis and hippocampus, and the structure laterally located are tapetum and tail of caudate nucleus. Inferiorly, there is one sulcus, that is a collateral sulcus, which forms an indentation that's called collateral eminence. So these are the structures that is located to the temporal horns. Through this temporal horn only, that is a choroid plexus, you can see it in that picture, choroid plexus, which is formed by anterior choroidal artery, enters into lateral ventricle. That's another MCQ. Through which horn the anterior choroidal artery enters into lateral ventricle? That's a temporal horn. You can see in that picture. Next, we will move on to third ventricle. Through questions only we can approach. Roof of third ventricle is formed by tila choroidea, anterior choroidal artery, vein of Galen, internal cerebral vein. So we can look into the picture. Here's one more question. The floor of third ventricle is not formed by. All these questions are previously asked questions only. It's nothing. I didn't make any questions. These are the questions which was previously asked, and we approach all these topics through previously asked questions. Floor of third ventricle is not formed by optic chiasm, tuber cinerarium, infundibulum, lamina terminalis. Another question. Lamina terminalis located lateral to third ventricle, anterior to third ventricle, posterior to third ventricle, inferior to third ventricle. So three questions were asked in the related to third ventricle. So with this, in this picture, this single picture itself will tells the third ventricle boundaries. The roof is formed by tila choroidea or ependymoma. They are telling the ependymoma. Actually, ependymoma contains tila choroidea, which contains choroid plexus. So choroid plexus forms the roof of the third ventricle, which separates the third ventricle from the fourth ventricle. Sorry, third ventricle from the lateral ventricle. Anterior wall is formed by anterior column of fornix, anterior commissure, and lamina terminalis. So lamina terminalis forms the anterior wall of the third ventricle, and The structures which form the floor of the third ventricles are optic chiasm, pituitary stalk, mammillary bodies, and then a part of that is a tegmentum of midbrain. So they will ask three out of four options. They will put three, and then they will put some other options. Usually they will ask MCQs in this topic in this way only. Laterally, the two structures which forms the third ventricles are above by thalamus and below by hypothalamus. And posteriorly, there are three structures: pineal gland, posterior commissure, that is called habenular commissure, and then there is a cerebral aqueduct through which it communicates to the fourth ventricle. So with this, we can approach this question. A roof of third ventricle is found by, see in this picture, tila choroidea. So that's the answer. And then floor of third ventricle is not formed by lamina terminalis, because lamina terminalis forms the anterior wall. See in that picture, anterior wall is formed by lamina terminalis. Lamina terminalis located anterior to the third ventricle. We'll move on to fourth ventricle. The fourth ventricle actually located behind the pons and medulla, not behind the midbrain. The floor of the fourth ventricle is very important. This fourth ventricle communicates to the subarachnoid space through foramen of Magenti. This is a single foramen in the center, and foramen of Lashka. There are two foramen of Lashkas on either side. To the spinal cord through central canal. We'll see the MCQ. All are true regarding floor of fourth ventricle except bounded by all three cerebellar peduncles. Obex forms the lowermost part. Vestibular area located medial to the sulcus limitans. Hypoglossal triangle located above vagal triangle. This is one of the frequently asked question. Floor of fourth ventricle. To crack this question, you should know. There is one more question. All the following cranial nerves are located in the fourth ventricle floor except abducens nerve, trochlear nerve, hypoglossal nerve, vagus nerve. To crack the floor of fourth ventricle, you should by heart this picture. You should memorize this picture. See this pictures. You can easily approach this picture. Look at the boundaries. All three peduncles forms the boundary of the fourth ventricle floor. See, above there is a superior cerebellar peduncle. Middle there is a round structure, that's the middle cerebellar peduncle, and inferior is the inferior cerebellar peduncle. The center there is one median sulcus, and there are two more sulcus, one on either side. That's a sulcus limitans. Name itself says that's a last sulcus that limits the facial colliculus, which is located in the center on the upper part. And then there is this floor of fourth ventricle is divided into upper part and middle part. That's pontine part and medullary part, which is separated by stria medullaris, which is related to the eighth cranial nerve. The importance of stria medullaris we will discuss in detail when we are dealing with neuro-otolaryngology topic. Then there are two triangles which is located in the medullary part, inferior part, hypoglossal triangle and then vagal triangle. Look, even though the hypoglossal nerve is the 12th cranial nerve, but the triangle is located above the vagal triangle, which is the 10th cranial nerve. So usually they will confuse in this way only. And then the lowermost part is called obex. Okay, with this we can solve the question. See, all are true regarding floor of fourth ventricle. Bounded by all three cerebellar peduncles, yes. Obex forms the lowermost part, yes. Vestibular area located medial to the sulcus limitans, yeah, we didn't discuss this. See, this vestibular part is located actually lateral to the sulcus limitans. The cochlear part and vestibular part, it's a cochlear area and vestibular area. These are the areas behind which, underneath which is the vestibular nuclei and cochlear nuclei located. There are 4 vestibular nuclei and 2 cochlear nuclei, which we'll see in detail on other class. So the vestibular area is located lateral to the sulcus limitans. That's the answer. And hypoglossal triangle located above vagal triangle. Yes, hypoglossal triangle is located above the vagal triangle. All the following cranial nerve located in the fourth ventricle floor except trochlear nerve, because trochlear nerve the trochlear nerve arises from the nuclei which is located in the midbrain. The fourth ventricle floor is found by the pons and medulla. So that's the answer. So all other nucleus which arise from pons and medulla will be located in the floor of the fourth ventricle, not the trochlear nerve. We'll move on to CSF. Wrong about CSF. Normal CSF pressure is 10 to 15 millimeter of mercury, formed only by choroid plexus. CSF is turned over 3 to 4 times per day. Normally contains polymorphonuclear cells. Rate of formation of CSF is the another question. CSF pressure in lateral decubitous is another question. Actually, it is written millimeter of mercury. We have to write that millimeter of water, not a mercury. Okay. We'll see the CSF pathway. CSF is an ultrafiltrate of plasma, which is produced by mainly by the choroid plexus, which is located lateral ventricles and also in the fourth ventricle. So when a plasma choroid plexus, the blood flow to the choroid plexus is 4 ml per minute. 10% of the blood flow is converted into CSF. That means that around 0.4 ml, 0.3 to 0.4 ml of ml is formed per minute. The CSF, once most of the CSF is formed in the ventricles, that too in the lateral ventricles and also in the fourth ventricle. This formed CSF, the CSF once produced is circulated in the lateral ventricles. Through the foramen of Monro, it enters into the third ventricle, and through cerebral aqueduct, it goes into the fourth ventricle, and through foramen of Mezenty and Leschka, it goes into the subarachnoid spaces, and also through central canal, it goes into the spinal canal. Finally, it goes into the convexity brain surface, that is the convexity surfaces, and through this and from that it reaches the superior sagittal sinus, which is located in the midline. In the superior sagittal sinuses, there are, see in this picture, there are arachnoid granulations through which the CSF is absorbed. So in this way, CSF is produced in the choroid plexus in the ventricle and absorbed in the arachnoid granulation in the superior sagittal sinus. So majority of the CSF was produced in the ventricles, but also CSF is produced in the spinal cords, that too in the dural root sleeve regions. Okay, 80% of CSF is produced in the choroid plexus. Also, CSF can be formed from the transependymal seepages from the nerve cells. The nerve cells, the ultrafiltrates of the nerve cells are the through ion exchanges, whatever the fluids which are collected in the intercellular spaces, which moves towards the ventricles, and through this ependyma it enters into the, and it is converted into CSF, enters into the ventricle. There are three main arteries on either side that supplies the ventricles, and through that, that is choroid plexus is formed by the three main artery through which the CSF was produced. One artery from the anterior circulation and two arteries from the posterior circulation. The anterior circulation artery is anterior choroidal artery, which is a direct branch of internal carotid artery, which enters into the lateral horn through lateral ventricle through temporal, and it anastomoses with the other two arteries, which is formed by the posterior cerebral artery. Lateral posterior choroidal artery and medial posterior choroidal artery are the branches of posterior cerebral arteries, which enters into the ventricles, and it anastomoses with the anterior choroidal artery and forms the choroid plexus. The choroid plexus in the fourth ventricle is formed by anterior inferior cerebellar artery (ICA) and also by the posterior inferior cerebellar artery, pica. Pica is a branch of vertebral artery, and nica is a branch of basilar artery. We will discuss in detail about all these blood vessels in a neurovascular classes. See, the total volume of CSF in adult is any time is 150 ml. The formation rate was 0.3 to 0.35 ml per minute. So total CSF produced was 450 to 750 ml per day. So 3 to 4 times the quantity of CSF was turned over per day. The normal pressure was 7 to 15 millimeter of fluid or water. It's clearly written centimeter of fluid. So the previous slide was wrongly written. That's a normal thing. Above 18 is abnormal. Some will say above 24 is definitely abnormal. So there is a gray area between 15 and 18. So for MCQ part, above, for Greenberg says above 18 is abnormal. So this is a normal CSF parameters. The osmolarity is similar to plasma. Sodium is also similar. Since osmolarity is similar, sodium also most probably will be similar. See, the positive ions are all less. For example, potassium K plus and calcium 2 plus, that's a clue, are less in CSF when compared to plasma, and negative ion, that is chloride, is more in CSF when compared to plasma. They will frequently ask these things. They will jumble with all these things. Usually they will ask the glucose part only, but sometimes they may ask is sodium, chloride, potassium, calcium and all. So the easy to remember is sodium is same, potassium and calcium is lower on in the CSF, chloride is higher in the CSF. pH is also little on the lower side, more on the acidic side, 7.33. So glucose, 2/3 of the plasma glucose is the CSF glucose. That's why always when we send a CSF for analysis, we have to simultaneously do a blood glucose level also. It's a plasma glucose level also. So normally it is a percentage, that is 2/3 of the plasma blood glucose is will be seen in the CSF. And there should not be any RBCs in the CSF normally. If there is RBCs or if it is a blood, then it is called, it either should be a subarachnoid hemorrhage or it should be it may be a bloody tap or it may be an infection. Similarly, the normal WBC count in adult is 3 or it varies from 3 to 5. The 5 to 10 is a gray area. If it is more than 10, then it is definitely abnormal. In newborn, 10 WBCs is a normal, but whichever age group, RBC should be nil. That's one of the another important MCQ, high yield area for MCQs. And then so for example, if you do a lumbar puncture and there is a bloody tap, there is a lot of blood in the CSF. So for each 700 ml, we have to minus 1 WBCs. For example, sometimes if a bloody tap spuriously will shows higher WBC count, then we should not think that it is a infection. So for that, for every 7, so for example, if it is a WBC count is 2000, then spuriously WBC count is RBC count is 2000. WBC count also spuriously will be elevated. To know the actual WBC count, we have to divide for every 700 cells of RBC, we have to minus 1 WBC. That's a clue. Similarly, if RBCs are there due to bloody tap, the protein count also spuriously will be higher. So for every 1000 RBC, we have to minus 1 milligram of protein. That's another MCQ. With that, we'll solve this MCQ. Wrong about CSF. So normal pressure is 10 to 15. It's not millimeter mercury. It is a centimeter of water. And another is formed only by choroid plexus, which is wrong. 80% only formed by choroid plexus. Others are formed either by a dural root sleeves in the spinal cord or through through ependymal cell seepage or through ependymal cells. CSF is turned 3 to 4 times per day. That is correct. Normally contains polymorphonuclear cells, that is WBCs. Yes, but RBC is usually nil. Rate of formation of CSF is 0.3 ml per minute. So they will confuse with 0.3, 0.03 a minute with hour. So we should be very clear. It is 0.3 ml per minute. And CSF pressure in lateral decubitous. That's also one confusing terminology. So usually we will do lumbar puncture in lateral decubitous position only. So they asked only a routine thing. So it is 10 to 15. Here also this is a typo error. It is not a millimeter mercury. It is centimeter of water. 10 to 15 centimeter of water. Because we are not measuring with the sphygmomanometer or mercury with the help of mercury. Not seen in CSF puncture in subarachnoid hemorrhage. Xanthochromia, cremated RBC, leukocytosis, normal opening pressure. To solve this question, we have to see this tabular column. This tabular column is taken from Greenberg. You can see this thing. Okay. So normally see the opening pressure is very high in subarachnoid hemorrhage because subarachnoid hemorrhage there is a blood which should not be there in the subarachnoid space was there. So because of this entry of blood, the opening pressure, that is when we puncture the dural tube through LP needle, that we will measure the opening pressure. Based on that only we will categorize various infections and also whether it is normal or abnormal. So if it is a bloody tap, if we inadvertently enter one of the epidural veins, the opening pressure will be normal. But in subarachnoid hemorrhage, the opening pressure will be always higher. Both will be bloody, but all these are it's a supernatant and colorless because it is a full RBCs. But in a subarachnoid hemorrhage, RBCs has already entered into the subarachnoid space and it was broken down. So you'll have a xanthochromic fluid also. And also repeated lumbar punctures. If you do a lumbar punctures one level higher than the previous puncture site, you will get a normal CSF in case of a bloody tap. But in case of subarachnoid hemorrhage, wherever you puncture, you will get only a blood stained CSF. So not seen in CSF is in case of subarachnoid hemorrhage is normal opening pressure. Always opening pressure will be high. So another frequently asked question is what size needle will use and what is the color of the LP needle. So the mostly in common practice we'll use 22 gauge needle, that is a black needle, or 20 gauge needle which is a yellow needle. If you want to use a wide bore needle, or in case of 2A needle, it is 18 gauge. So 18 gauge needle comes in a pink color. For pediatric we use 24 or 25 gauge needle. 24 is a purple and 25 is a orange. So in that entire range, you have to remember only these 5 things: 22 gauge, 20 gauge, 18, 24 gauge, and in between is the 21 gauge. That is a green color. So this is a picture. They will put these pictures and they will ask what is a needle. So this is a 2A needle. To insert lumbar subarachnoid drain or to insert a lumboperitoneal shunt, we use 2A needle. 2A needle is 18 gauge wide bore needle. It is 8 centimeter in length. For each centimeters, there will be a color different. There will be a pattern variation. You can very well notice brown and silver for every 10 mm. There will be a markings, so that we should know how much centimeter we inserted. The total length is 8 centimeter, and it is 18 gauge needle. Okay, we'll move on to hydrocephalus. So this question was asked in AIIMS. Communicating hydrocephalus occurs in periaqueductal tumors, tuberculous meningitis, posterior fossa tumors, colitis. to crack this MCQ, we should know what is communicating hydrocephalus. Am I audible now?
Yes, sir.
Yeah. So hydrocephalus is broadly classified as communicating hydrocephalus and non-communicating hydrocephalus. So what is communicating hydrocephalus? If a patient, if there is an hydrocephalus and still the CSF is communicating through foramen of Mejenty and foramen of Lashka, then it is called communicating hydrocephalus. So what actually given in book is, if a CSF is freely communicating into the subarachnoid space, then still there is a hydrocephalus, then it is called communicating hydrocephalus. If CSF is not freely communicating into the subarachnoid space and there is a hydrocephalus, then it is called non-communicating hydrocephalus. There is other terminologies called like hydrocephalus ex vacuo. That means that if there is a cerebellar atrophy, because CSF is a closed, brain located in a closed space in the skull. So when a brain volume reduces, automatically the rest of the space is filled by CSF only. So the ventricles will automatically dilated. So if a ventricle dilated due to cerebral atrophy, then it is called hydrocephalus ex vacuo. So due to the vacuum created by the loss of brain parenchymal volume. And there is an entity in pediatrics called external hydrocephalus. That is, there is a fluid collections in the cerebral convexity space, which is seen in pediatric age groups. That is called external hydrocephalus, which is not actually an hydrocephalus. And there is an entity called hydranencephaly. This is one of the congenital anomalies where there is a blockage in the middle cerebral artery or internal cerebral arteries during developmental period itself, that causes loss of brain parenchymal volume or atrophy of a cerebral part, which causes hydrocephalus. And there is one absurd term called aortic hydrocephalus, which is not at all used nowadays. It is due to otitis media infections. Raised ACP due to otitis media infection is called aortic hydrocephalus, which we are not using. So these are all pseudo hydrocephalus. There is another entity called normal pressure hydrocephalus, an entrapped fourth ventricle, and arrested hydrocephalus. So, communicating hydrocephalus occurs in periaqueductal tumors? No, because periaqueductal tumors means the tumor located in the aqueduct region, which is between the fourth ventricle and third ventricle. So, it blocks the ventricle flow. So, the CSF is not communicating to the subarachnoid space. So, it is an obstructive hydrocephalus, that is non-communicating hydrocephalus. Tuberculous meningitis. Here, mostly the hydrocephalus is due to inflammation of the subarachnoid, inflammation of the arachnoid villi located in the sagittal sinuses and also in the convexity region. So, because of that only, majority of the TB meningitis will cause a hydrocephalus, but also sometimes it may produce an obstructive hydrocephalus, which is non-communicating hydrocephalus. But among the four answers, this is the only thing closer to the communicating hydrocephalus. So actually, all four will cause obstructive hydrocephalus, but among the other three, among the other four, this is the least possible thing which causes communicating hydrocephalus. Posterior fossa tumors obviously will cause obstructive hydrocephalus. Colitis, which is most commonly located in the foramen of Monro, that is between the lateral ventricle and third ventricle, that causes obstructive hydrocephalus. See in this picture, the first picture shows a CT of a hydrocephalus. The second picture shows CT of a hydrocephalus due to ex vacuo dilatation of ventricles. That is, there is a diffuse cerebral atrophies which are seen on the widened sylvian fissures and also convexity spaces. While we are dealing with neuroimaging classes, we will tell in detail about the how to read a CT or how to approach a CT MRI imaging of the brain. There is one congenital entity called X-linked hydrocephalus. which is due to L1 CAM molecule mutation, that is adhesion molecules, which is responsible for migration of the axons from one place to other. Because of this mutation, this is located in the long arm of X chromosome. Because of this, there will be an hydrocephalus. Along with hydrocephalus, the patient will also have corpus callosum hypoplasia or agenesis, mental retardation, adducted thumb, and spastic paralysis, which are altogether called crash syndrome. So C for corpus callosum hypoplasia, R for mental retardation, A for adducted thumb, S for spastic paralysis, and H for hydrocephalus. And then see the MRI image. This is the MRI image of a sagittal image which shows the entrapped fourth ventricle. Here, fourth ventricle alone was dilated. So, multiple shunt surgeries or post-infectious causes are the most common causes of entrapped fourth ventricle. Sometimes posterior fossa tumors or post-radiations may cause this entrapped fourth ventricle. Surgery is the treatment of choice. So, what shunt we will use is either nowadays these are shunt tubes are not used nowadays. Endoscopic approaches, we can tackle these things through posterior fossa midline approach. We can do endoscopically. We can approach this entrapped fourth ventricle. We can create a space and then we can place a shunt tube through endoscopic also. The shunt tube which is used are is called Torkelson shunt. That is, the shunt tube will extend from ventricle space, that's fourth ventricle space, to cisternal space. Usually will drain into cisterna magna, which is located behind the cerebellum. So how will you tell whether hydrocephalus is there or not? So there are certain criteria based on CT and MRI. We can say there is an hydrocephalus. So two ways we can conclude, we can say it is hydrocephalus. One is a clinical thing, which is there will be a telltale sign in pediatrics, not in adult. Adult will always present with raised ICP or memory disturbances or altered sensorium. Children will have a lot of various range of signs and symptoms. Apart from that, based on images, we can say whether hydrocephalus is there or not. See, in this picture also taken from Greenberg. This picture shows that the temporal horn, TH means temporal horn. The temporal horn width is greater than or equal to 2 mm, and the sylvian and intrahemispheric cerebral sulci are not visible, that is closed. Or temporal horn is greater than or equal to 2 mm and a ratio of frontal horn divided by interdiploic distance. It's shown in the second picture. FH means frontal horn. You take a diameter of the frontal horn and also the inner diameter of the at that level, frontal horn level. So if you divide these things, if it is greater than 0.5, then it is hydrocephalus is confirmed, along with if a temporal horn is dilated more than 2 mm or equal to 2 mm. This is the normal. Frontal horn divided by inner diameter ratio, if it is 0.4 or less, then it is normal. See, the first picture shows there is a Mickey Mouse head like features of the seen in the first picture. When the Mickey Mouse head is, the head formed by the tears are formed by the lateral ventricle. So it looks like a Mickey Mouse head. So this is called Mickey Mouse sign. This is one of the repeated asked MCQs. Mickey Mouse sign. All these red things are all frequently asked multiple choice questions, or one of the options of the multiple choice question. Then there will be periventricular lucency, which I will show in the subsequent slides. And the most important thing is Evans ratio. So they will ask questions in the Evans ratio. The Evans ratio is actually a ratio of frontal horn diameter and then biparietal diameter, not the inter diameter at that level. You have to take the biparietal diameter. The most prominent parietal region, we have to measure the inner diameter at that level. So if you divide that, if it is greater than 0.3, then there is an hydrocephalus. The other thing is thinning or upward bowing of corpus callosum. So another MCQ, which is not a sign of raised ICP in children. Papilledema, McEwen sign, sutural diastasis, sunset sign. We'll see. Sunset sign seen in syringomyelia, hydrocephalus, porancephaly, craniosynostosis. Features of raised ICP except headache, diplopia, altered sensorium, primary optic atrophy. So we'll see the symptoms, signs and symptoms of hydrocephalus in children. So in case of acute hydrocephalus, the occipitofrontal circumference is above 2 standard deviations. So for a newborn child, the normal head circumference is 33 to 35 centimeter. So every month, the head circumference is increased by 2 centimeters for first 3 months and 1 centimeter for next 3 months and then 0.5 centimeter for next 6 months. This is the rule of thumb. So if you actually want to calculate whether it is really a hydrocephalus is there or not, then we have to put the chart and then we have to see it in the standard deviation things, which is very cumbersome. So we are not following it in clinical practice. So for MCQ only, it is whether it is a 2 standard deviation or 1 standard deviation, they will ask. So usually there is 2 centimeter growth in the first 3 months, 1 centimeter per month in the next 3 months, and then 0.5 centimeter per month in the next 6 months. Then there will be a bulging fontanelle. Child will be irritable. It shows will be lethargic, altered sensorium, and will have vomiting. There will be dilated scalp veins, and eyes upgaze perisis will be there. That is called sunset sign. See, look into this picture. The first picture shows a sunset sign. There is upgaze perisis, and a pupil and cornea was is located more downwards. And the second picture shows a dilated scalp veins with large head circumference. Then patient will have McEwen's sign. McEwen's sign is if you compress the skull, there we will feel the crackpot. We'll have a crackpot like feel, a broken pot feel, because of the sutural diastasis. All these bones will be separated, and if you compress now, there is a water inside now. Because of this compression in the pediatric skull, will feel like a crackpot. We'll have a crackpot feel. That is called McEwen sign. The patient will have exaggerated reflexes, especially in the lower limb, because the lower limb fibers, there is a corticospinal tracts are located is going through genu of internal capsule. So because of the dilatation of the lateral ventricles, the genu of internal capsule is compressed. That's why the patient will have a upper motor neuron signs. That's a exaggerated reflex is one of the upper motor neuron signs, and patient will also have upgoing plantar. There will be irregular respiration with apneic spells because of the compression of the respiratory centers at the fourth ventricle levels, either due to herniation of the tonsil because of raised intracranial pressure, or due to direct compression if the fourth ventricle is dilated, and there will be sutural diastasis. Chronic hydrocephalus features are silver or copper beaten appearance. This is the third picture below shows the X-ray of the silver or copper beaten appearances. So this is one of the frequently asked shown images, and they will ask what is this. Usually the differential diagnosis they will keep some other things, but this is the classical silver beaten appearance. There will be erosion of sella turcica because of raised ICPs. There will be an empty cella. Cella was empty because the CSF will occupy that space and it will compress the pituitary and will push the pituitary to one side. So in a CT or MRI, the cella appears empty. In case of chronic hydrocephalus, because of this hydrocephalus and pulsatile thing, the cella floor will be thinned out and eroded. There will be macrocrania because of increased head circumference. atrophy of corpus callosum. The child will always have a failure to thrive, and there will be delayed fontanel closure because of hydrocephalus and increased head circumference. So not a sign of raised ICP in children is, it's not actually papilledema, because if antennal fontanel is open, so there will not be much pressure to the retina or optic nerve head. So there will not be papilledema, or papilledema will be, if in case of antennal fontanel was closed, then the child will slowly develop papilledema, which is later thing. The other things are commonly seen signs of raised ICP, that is hydrocephalus in children. And sunset sign is seen in hydrocephalus. Features of raised ICPs are except headache, diplopia, altered sensorium, everything will be there in a raised intracranial pressure. There will be secondary optic atrophy, not a primary optic atrophy. So what is the difference between primary and secondary optic atrophy? We will deal in the neuro-ophthalm class. This is the CT and MRI images, which shows the periventricular lucency in hydrocephalus. So they will put this image and they will point out what is this. So this is the periventricular lucency seen in hydrocephalus, and the second image in MRI is a FLAR image, and the third image is the T2 weighted image. We will tell what is the difference between FLAR, T2 weighted, T1, now all these terminologies in the MRI class. Next question. 1.5-year-old child presented with enlargement of head size with the features of raised ICP. CT scan showed dilated lateral and third ventricles. What is the treatment of choice? So it's a direct question. What is the treatment of choice for hydrocephalus? So the treatment of choice for hydrocephalus is ventriculoperitoneal shunt. VA shunt means ventriculoatrial shunt. Before the invention of ventriculoperitoneal shunt, they tried various other routes, whether places, whether someone tried into the atrium, someone tried into the pleural space, and someone tried into the subgaleal space. All have their own complications, and ventriculoperitoneal shunt has the highest success rate when compared to other things. LP shunt means lumboperitoneal shunt or thecoperitoneal shunt. ETV means endoscopic third ventriculostomy. We will see in subsequent slides. So the answer is ventriculoperitoneal shunt. As the name itself says, ventriculoperitoneal shunt. So we will connect the ventricles, one of the ventricles, usually the lateral ventricle we will connect, and we will do a subcutaneous tunneling and we will connect it to the peritoneal cavity. So the point of entry is called Keen's point. While we are dealing with surface anatomy classes, we will tell all those points. There are 4 important points you should know in neurosurgery. They will ask frequently in entrance examination. So for a shunt, the point is called Keen's point. It is in the middle of this is 3 centimeters above the ear. We have to mark, and then 3 centimeter from that mark 3 centimeter behind. So that's called Keen's point. So through the Keen's point, we at a 4 or 5 centimeter depth, usually it's a 4 centimeter depth, but the depth may varies based on the head circumference, based on the hydrocephalus size. We'll enter into the lateral ventricle. This is a picture which shows the ventriculoperitoneal shunt tube. This is 3 important parts of the shunt tube. One is the cranial end, which is shown in the picture is shown below. There is a marking, that the marking in that cranial end, and then there is a reservoir which is shown in the that upper part. There is a reservoir, and then there is a long abdominal end. So through this cranial part, the ventricle was tapped, and then this cranial part was connected to the reservoir, and then the reservoir is connected to the abdominal end. We will do subcutaneous tunneling, and then we will put the shunt tube into the peritoneal cavity. So this is a picture that shows the thecoperitoneal shunt. They will ask all these things. What's the difference is, this thecoperitoneal shunt does not have a reservoir. So we should be careful what shunt tube they are showing. So if there is a reservoir, then it is a ventriculoperitoneal shunt. There is no reservoir, then it is a thecoperitoneal shunt. Below that, the two-hay needle are shown. So they will insert this lumboperitoneal or thecoperitoneal shunt through the two-hay needle. This is a CT scan showing a shunt tube in situ. See the radio opaque thing which enters into the lateral ventricle. This is the X-ray that shows the thecoperitoneal shunt in place. So they will put this X-ray and they will ask what procedure was done, or they may ask that what is this. So it is a thecoperitoneal shunt. It is done for raised intracranial pressure. There is an entity called idiopathic intracranial hypertension, which will deal with the subsequent topics, especially in when we deal with cortical vein thrombosis. We will tell that idiopathic intracranial hypertension also. So treatment of choice is a thecoperitoneal shunt. So this is the X-ray shows the thecoperitoneal shunt. All are complications of shunt except it has a 5% risk of seizure. CNS tumors can metastasize through shunt. Most common site of obstruction is peritoneal end. Most common site of erosion is clavicle. So to solve this thing, we should know what are the complications of shunt surgery. There's one more question. Which of the following are complications of ventricular peritoneal shunt surgery? Over shunting, under shunting, infection, shunt ascites, pseudosis. This was a question asked in PGH Chandigarh. So in PGH Chandigarh, there will be multiple answers might be correct. So in this question, all answers are correct. All are complications of VP shunt surgery. So we'll see complications of shunts. One of the main complications is obstruction. The most common region of obstruction is the proximal end, not the peritoneal end. So it was asked in the MCQ. So the most common site of obstruction is the peritoneal end. So if you know this, what are the complications? What is the most common site of obstructions and all these things? You can solve this question. So the most common site is the cranial end. It is because of choroid plexus might grow into the lumens of the shunt, or it will cover the lumens of the shunt, or shunt tube might migrate into the brain parenchymas, and these are the two main reasons for obstructions. And other reasons are if there is a protein content is high in the ventricles or CSF, that may go and block this thing, or if there is a infections that may block the, it will forms a filmy layer around the shunt tube and it will block the shunt tube. So other complications are disconnection of the shunt tubes. So we have to tie all these parts, the cranial end, reservoir, and the abdominal, and everything has to be secured in a proper way. Otherwise, there will be a disconnection. In case of children grows, the disconnection rates are more. So we have to be very careful in case of when you are doing a shunt for child. Then there might be hardware erosion. I will show in one of the slides what is hardware erosion. That is, the shunt tube may erode into, if a patient is have a chronic failure, as a failure to thrive, the skin will be thinned out, so the shunt tube may come out. The most common site of a shunt tube erosion is the clavicle region. This is a prominence and it is against the bone, so that's the most common site. There will be tip migration. It may go into the brain parenchyma, or totally the cranial end may get disconnected from the reservoir and it goes into the shunt tube also, into the ventricles. And another complication is infection. Either it may be a cranial part might get infected, or the peritoneal part may get infected. The most common part of infection is a cranial infection. Then that might be intracerebral. While we are introducing shunt itself, it's a blind procedure. So while we are introducing the shunt tube, it may cause intracerebral hemorrhage, or it may cause intraventricular hemorrhage. So another complication is a seizure. 5% risk of seizure is there. As I told, we enter into the ventricle through the brain parenchyma. So there might be irritant, there might be a bleed, there might be a small micro bleeds that may stimulate, that may trigger a seizure. Shunt tube itself is a foreign material, so sometimes it may trigger a seizure. So there is a 5% chance of seizures. So always we should cover these patients with anti-epileptic drugs. Then some of the some of the tumors might migrate or might transmit through the shunt tube into the extracranial site. So the tumors which metastases are medulloblastoma or PNET or other most common tumor is ependymoma. There is one more complication, the slit ventricle syndrome. Name itself says the ventricle will be in a slit shaped manner. So patient will have a raised ICP features. When you do a CT scan, ventricles will not be dilated, or the shunt failure will not be seen. It might be intermittently, because if there is an intermittent obstruction, the shunt tube lumen was obstructed, then patient will have a raised intermittent. That itself will automatically open the shunt tube and CSF will be drained out. So if you do a CT scan, there will not be a dilatation of ventricles in this thing. That's why it's called slit ventricle syndrome. Then very rare and remotely, it may cause inguinal hernia, hydrocele or intestinal obstruction. So most common shunt infections are staph epidermidis. Based on the, if it is within 6 months, then it is called yearly shunt infection. If infection occurs after 6 months, it is called late shunt infection. In case of neonates, most common bacteria causing shunt infection is E. coli. In case of fungal infection, most common thing is candidal infection. Some patients may present with acute renal failures. In case of if a shunt infection was not treated in a proper way, if there is a subclinical infection, then this will cause acute renal failure. That is called shunt nephritis. If you collect a CSF, you do a lumbar puncture, if you collect a CSF, the culture yield will be very high, or if it is if the CSF WBC count is more than 10,000, at least if it is more than more than 20,000, then there will be a high yield in a culture. The treatment is a three things we have to do: medical and surgical management. Medical management is we have to give either intravenous or intrathecal antibiotics based upon the severities and based upon the antibiotics and culture sensitivity. So intrathecally, certain antibiotics we can give. One is most common antibiotics which are given through intrathecal is meropenem, and also we can give aminoglycosides intrathecally. Dosage we need to be very careful. We need to be adjusted. It should not be. It is not like the other dosages. It has to be very minimal. The other thing is we have to exteriorize the shunt. Most commonly, the distal end has to be exteriorized, and we have to send the CSF for analysis. And if we have to treat the patient with antibiotics, and 3 subsequent cultures was negative, then only we can replace the shunt tube. The cranial abdominal end was removed, and we can connect the abdomen in different places. Another thing is we can remove the shunt tube in total if it is if it shows very high CSF count and say patient was clinically deteriorating. We can remove the shunt tube if it is placed within 6 months. If it is more than 6 months, generally we should not remove the cranial end unless otherwise a patient is persistently having a shunt infection. Then we have to remove the cranial end also. Removing of a cranial end of the shunt tube on a chronic on a patients or on a later date after a shunt surgery means this around the shunt tube, the choroid plexus may form neovascularization or will form will grow around that thing. So if you remove the shunt tube, it will produce a bleed, intraventricular bleed. So we have to be very careful on if a shunt surgery was done on a way back. So this is one of the complication of shunt surgeries. This is a CT picture that shows a subdural hygroma. If it is a over shunting, the shunt tube drains more, means the ventricles are already collapsed. We didn't see the ventricle, but we can see the shunt tube. And because of this over drainage, it causes a subdural hematoma. Subdural hematomas are due to rupture of the cortical veins. So because of the over shunting, the pressures are reduced and it causes a disturbance or a tear in the cortical veins, which causes subdural hematoma. This is another picture which shows a shunt erosion where the reservoir is seen behind the ear. The most common place is the clavicle. So all our complications are shunt except, yeah, there is a 5% risk of seizure. CNS tumor can metastasize through shunt, and most common obstruction is not the peritoneal end, it's the cranial end. And most common site of erosion is clavicle. Next, we move on to endoscopic third ventriculostomy. Structures can get injured through ETV except hypothalamus, fornix, posterior communicating artery, oculomotor nerve. For that, we should know what is ETV and what is the structure of a third ventricle, or what are the structures we are going to pierce, or how ETV functions, we should know. One more question. During ETV, which sector is least likely to get damage? Mammillary body, fornix, habenular commissure, anterior commissure. So this is a picture which shows the endoscopic third ventriculostomy. Rigid endoscopes are used. Sometimes for ETVs, always rigid endoscope is preferable. GAB endoscope is used. So the endoscope will say the incision or the burr hole is made based upon the sagittal images of the MRI. That will be ideal. Or roughly, we can put a burr hole just in front of coronal sutures, so that we can enter into the lateral ventricle, then into the third ventricle. But ideally, we should preoperatively we should look into the sagittal image of the MRI. Then only we can plan the incision. So once we enter into the lateral ventricle, we can see this. That is the foramen of Monroe, and whether which ventricle was entered, we can locate the ventricle. We can sometimes the ventricle was largely dilated, we can inadvertently enter into the opposite side. Even though if you put an incision and enter into the right side, we can inadvertently enter into the left side. So to know the side of the ventricle or which lateral ventricle we are in, we have to trace the choroid plexus and thalamostriate vein. The choroid plexus is always located medial to the thalamostriate vein. If it is in the this picture shows the right lateral ventricle. So anteriorly there is a choroid nucleus, and then medially in front of the choroid plexus there is a fornix, and then through foramen of Monroe we can enter into the third ventricle. Once we enter into the third ventricle, we can see these structures. One is the floor of the third ventricle that is formed by the optic chiasm, and behind it is a pituitary stalk or infundibular recess, and behind is the floor of the third ventricle, and then mammillary bodies, and behind the mammillary bodies are the midbrain tegmentum of midbrain. So between the optic chiasm and the mammillary bodies, that is between the infundibulum and the mammillary body, we have to puncture the floor of the third ventricle. That is the principle of endoscopic third ventriculostomy. We use Fogarty catheter, that is 4 French catheter, to pierce the floor of the third ventricle, and then we will inflate the balloon so that third ventricle will be open, and it is one of the treatment for hydrocephalus. Especially in case of obstructive hydrocephalus, when the posterior third ventricle is obstructed, as acute, or in a congenital hydrocephalus like aqueductal stenosis, or any tumors in the posterior third ventricle or in the fourth ventricle, it is one of the treatment choice. Instead of VP shunt, we can do endoscopic third ventriculostomy. So we in this endoscopic third ventriculostomy, we pierce the third ventricle so that the third ventricle is directly communicated into the cisternal space, perimesencephalic and perimesencephalic cisterns. So the underneath is the, if you rupture, there is, see the base of the third ventricle, there is a basilar artery that is in just in front of the mammillary bodies. Below it's a basilar artery will come. So if you puncture it in a very, if you strongly push the Fogarty catheter, it may puncture the, it may disturb or it may damage the basilar artery. Or if you inflate the Fogarty balloon below the third ventricle, that may damage, sometimes damage or create a bleed in the cisternal space due to the damage to the basilar artery. So this is one of the frequently, they will show this image and they will ask to find what is the structure which is highlighted, or which they will highlight the mammillary bodies and will ask what is the structure we will see into the endoscope, or where will you, they will highlight or they will point out where will you where will you pierce when you use when in case in that ETV procedure. The structures can get during endoscopic third ventriculostomy is, yes, hypothalamus, which is located on either side, may get damaged. Fornix is located here in the just above the foramen of Monro. So when we enter into the third ventricle, we may damage the fornix, especially if the trajectory was not chosen in a proper way. Will definitely damage the fornix. Posterior communicating artery, no, it is not posterior communicating artery, it is a basilar artery, because that's located in the floor of the third ventricle, which will get damaged in a ETV procedure. And oculomotor nerve, yeah, oculomotor nerves is arises from the midbrain and it goes anteriorly. So when it is closely located next to this basilar artery region, so sometimes we may damage the third nerve also. So the question answer is posterior communicating artery. It's a basilar artery, not the PCOM. So ETV has a low success rate. When there is a previous shunt surgery was done, in those patients, if we do ETV, the success rate is very low. In case of infection, we should not attempt ETV, or ETV will have only less success rate. Previous subarachnoid hemorrhage will also have, because a lot of adhesions will be there in the cisternal space. So ETV failure rate is very high. Our patient already have a whole brain radiotherapy, WBRT. Also, cisternal space will be irradiated brain, and there will be thickened. All these arachnoids are all thickened, so the failure rate of ETV is more. In case of tumors, also the failure rate is more. Treatment of hydrocephalus is all except acetazolamide, third ventriculostomy, ventriculoperitoneal shunt. So the medical management is either we can give a mannitol, or in acute basis we can give Lasix, or we can give acetazolamide. Lasix, there is a furosemide. Ventriculoperitoneal shunt and third ventriculostomy are all treatment of choice. Previously, choroid plexectomy was done in initially early 1900. But nowadays, nobody is doing choroid plexectomy. So the answer is choroid plexectomy. Then we'll move on to normal pressure hydrocephalus. This is one of the frequently asked questions related to hydrocephalus. So far, I had gone through some of the papers. Each paper has one question related to normal pressure hydrocephalus. So what is a triad? What is normal pressure hydrocephalus? Normal pressure hydrocephalus is a triad of dementia, urinary incontinence, and gait disturbance. So this is one of the important tabular column shown in Greenberg. So it says that it should be an insidious. It should be an insidious onset. It should be duration should be more than 3 months to 6 months. Age of onset should be greater than 40 years, and there should not be any antecedent head trauma or intracranial bleeds, and it should be progressive in nature. And the brain images should show the ventricular enlargement, and Evans ratio should be greater than 0.3, like any other hydrocephalus. There should not be any obstructive hydrocephalus features, and one of the following should be there, which is a supportive things. Either enlarged temporal lens are not entirely attributable to hippocampal atrophy, and callosal organ angle should be greater than 40. See in this picture, this is a callosal angle, so it should be more than 40 degree. Callosal angle is nothing but the angle made by the corpus callosum, which is located above the lateral ventricle. So they will show this picture and they may ask what is this, or what is the importance of callosal angle, or what is the callosal angle, critical angle, which is needed for the diagnosis of normal pressure hydrocephalus. and then there should be a flow void in the MRI, either in the aqueductal or in the fourth ventricle region. See in this picture. This picture shows this MRI image shows the flow void. It's a black dot you can see in the aqueduct region and also in the fourth ventricle outlet. So these two are called flow voids. That there is no, it will be picked up in this MRI, T2 weighted MRI, and it will be black. So these are the criteria for NP. These are the criteria, image criteria for NPH. Clinically, patient should have three important things. One is the gait disturbances. A patient should have a decreased step height, decreased step length, decreased cadence, that is the speed of walking, and then there will be sway. Overall, it is called frontal gait. So once we are dealing with the gait classes, we will take in detail about various types of gait. So next is a cognitive, both psychomotor slowing and also executive function will be slowed, and there will be behavioral disturbance also. And then patient will have urinary disturbance in the form of urinary urgency, increased frequencies. When will you call increased frequencies? If voiding is more than 6 times in 12 hours with a normal fluid intake, then we will call it is increased frequency. And not nocturia. Patient will have a nocturia. When will we say it is a nocturia? When a patient voids more than 2 times averagely in a night, then it is called nocturia. So the triad of NPH is dementia, urinary incontinence, and gait disturbance. So this is a picture showing a programmable shunt. The treatment of choice for a normal pressure hydrocephalus. That's one more MCQ. Is a programmable shunt. What is mean by programmable shunt? That means that usually the shunt will have that reservoir will have a pressure settings. Either it is a low pressure, medium pressure, or a high pressure. That will be comes in a marking. Usually, majoritarily we use medium pressure shunt tubes. The pressure settings will be between 65 to 90 centimeter of fluid. So that is called medium pressure. So, but if you keep the shunt tube inside, the pressure cannot be adjustable in a normal ventriculoperitoneal shunt. But in case of programmable shunt, using a magnet, we can adjust the shunt pressure or a shunt of opening pressure or valve pressure. We can adjust manually externally. So usually it will be in a one particular set pressure will be in a one particular pressure, and based upon the clinical improvement or clinical deterioration, we can adjust the pressure without opening the shunt or without doing a surgery. We can do it in a bedside itself. That's the biggest advantage of programmable shunt. So this is a picture. A shows that X-rays of the this is the image of the programmable shunt reservoir, and that the dial was zoomed and it was shown that the pressure settings will be between 30 to 200. That's another MCQ. 30 to 200 is the pressure settings, and there will be an indicator which is a radio opaque. We can pick up that indicator, and based upon the indicator location, we can see the we can notify the what is the pressure setting. Usually the pressure setting is between 90 to 100, and based upon the clinical thing, we can adjust the pressure setting. This is the image that shows the reservoir, also the dialer programmer. The below is the blue color thing is the programmer, and there is the right side picture shows the patient with the programmer. So we can adjust externally using this programmer magnet. We can adjust the pressure. This is the X-ray that shows a programmable shunt. See, the X-ray has to be taken in a proper way. That means that the X-ray, the rays has to enter the patient first. That is a programmer first, and then the plate should be kept on the other side. Then only these X-rays we can read this X-ray. If you do it in a wrong way, then the direction will be in a just mirror image of this, and we may mistakenly take that pressure is high. So always the ray should enter from the programmer side, that is from the shunt side, and then the plate should be kept on the opposite side. So we'll move on to another topic. It is a blindness following hydrocephalus. There are three reasons for blindness following hydrocephalus. One is the occlusion of the posterior cerebral artery by transtentorial herniation, either upward herniation of or downward herniation. Downward herniation is through the occipital lobe or by the occipital lobe, or upward herniation is by the cerebellum. So because of raised intracranial pressure, posterior cerebral artery might get occluded. That will cause cortical blindness. We'll tell in detail about cortical blindness when we are taking neuro-ophthalm class. Then, due to dilatation of third ventricle that directly compress the optic chiasm, that may cause blindness, or due to chronic raised intracranial pressure, patient may have a papillary edema and secondary optic atrophy. So the other way we can classify this blindness as a pre-geniculate blindness and post-geniculate blindness due to hydrocephalus. Pre-geniculate means before the lateral geniculate body. If there is the reason is before the lateral geniculate bodies, in case of a dilatation of third ventricle or due to chronic papillary edema, the patient will have marked optic atrophy, will have a reduced pupillary reflex and normal sensorium. In case of occlusion of a posterior cerebral artery, patient will have a reduced or altered sensorium, will have a normal pupillary reflex because lateral geniculate body is paired. So patient will have a normal pupillary reflex, and then patient will have a cortical blindness. Thank you. So today's class is regarding a lateral ventricle, CSF, and hydrocephalus. I told in a nutshell. There are a lot of other potential MCQs areas are there apart from this, which we will subsequently deal in other classes. When we are taking other classes, we will interlink with this, and also through mock exams and also through revision classes and revision exams, we will deal the rest of the topics, or whichever left behind topics regarding the ventricles, lateral ventricles, CSF and hydrocephalus will be dealt while we are going through subsequent classes. I hope you understand this anatomy of lateral ventricle and also nutshell of CSF and also about hydrocephalus. So we'll meet you in a next class. Thank you.